So I guess, Jessica, I will hand it over to you.
Different spot trying to connect.
And our attendees can hear us, Dr. Ram.
Okay, wonderful. Can you all hear and see me okay now?
Yes.
Okay, perfect.
Welcome, everyone. Good morning or good afternoon now. Happy 6th Annual UCSF International Women's Day celebration. And thank you for joining the Pelvic Floor Health Throughout the Lifespan panel. I'm going to do some land acknowledgements here. So we would like to acknowledge the Ramaytush Ohlone people who are the traditional custodians of this land. We pay our respects to the Ramaytush Ohlone elders, past, present, and future, who call this place and the land that UCSF sits upon their home. We are proud to continue that tradition of coming together and growing as a community. We thank the Ramaytush Ohlone community for their stewardship and support, and we look forward to strengthening our ties as we continue our relationship of mutual respect and understanding. And I am going to pass it on to Tiffany Louie, who is the Administrative Director of Women's Health OB-GYN, Center for Pregnancy Options and Minimally Invasive Gynecologic Surgery and Urogynecology.
Thanks, Jessica, for kicking us off, and happy International Women's Day. And thank you to everyone for joining us today. I have the privilege of working with and introducing our panel of amazing women urogynecologic surgeons today, starting with Dr. Olga Ram, our chief of our division of minimally invasive gynecologic surgery and Center for Urogynecology and Women's Pelvic Health, and a reconstructive pelvic surgeon with expertise in minimally invasive and robotic techniques. Next, Dr. Abigail Schackenmer-Golez, also a urogynecologist who specializes in treating pelvic floor disorders and educates medical students and has won multiple awards for her teaching. And also Dr. Caitlin Painter, who is a urogynecologist and pelvic medicine and reconstructive surgeon who specializes in treating pelvic floor disorders. So without further ado, I present to you our extraordinary urogynecology team.
Thank you, Tiffany, for that kind introduction. Should I plan to share my screen?
Yes,
So
correct, Dr. Ram.
we can bring up the slides. Okay, great. Give me 1 second here. Okay, and let me just.
If you're having a hard time, I can also try to share too.
Okay, I'm sharing it. I'm just trying to go to presentation mode.
This is we need the different slide set.
Oh, whoops. Okay, do you mind sharing them?
All right. So just stop share and I'll share my screen.
Thank you.
Okay. Okay. And all right, there you go.
All right. Good afternoon now, everyone. And thank you so much for taking the time out of your day to join us and learn a bit more about pelvic floor disorders. We are really excited to be a part of this lecture series honoring International Women's Day. Pelvic floor disorders are incredibly common, as you'll hear us talking about, and they have a profound impact on women's quality of life. but they remain on the fringes of our awareness, both as medical professionals and also as patients. One of my favorite mentors used to call it the sisterhood of silence. And so my colleagues and I think I speak for all of us when I say that we're grateful to take this opportunity to break the silence around pelvic floor disorders. Can you go back to the last slide? So I know Tiffany introduced us. I'll just reiterate so you can put names with faces. I'm Olga Ram. I'm the Division Chief of Urogynecology and Reconstructive Pelvic Surgery. I'm relatively new to UCSF, having recently joined after leaving my practice at Kaiser Permanente in the East Bay, where I served as the Regional Chief of Urogynecology for Northern California. And Dr. Painter, let me just pass the baton briefly to you.
Sure. Hi, I'm Caitlin Painter. It's nice to meet you all virtually. I'm an assistant professor here, a urogynecologist, and I'm going on my third year here. And some of you have maybe heard me speak before about pelvic floor disorders, but very excited to be here today. And off to you, Abby.
And hi, good afternoon. I'm Abby Shakin-Margolis. I'm rounding out now my second year here at UCSF. I couldn't be happier than to partner with these two amazing women in our goal to build a urogynecology division that's a robust group of people to see our patients. Really happy to be here today.
Thank you both. All right. So our objectives aim to provide information about pelvic floor disorders to you all, both as healthcare providers, but also as potential patients or the friends, neighbors, and family members of patients with pelvic floor disorders. Go to the next slide. So before we delve into pathology, let's just take a moment to talk about the pelvic floor, which is pictured here. The pelvis, as we know, has roughly the shape of a bowl, and the base and sides of the bowl are made of muscles and connective tissue, and these collectively are referred to as the pelvic floor. The pelvic floor muscles interface with the hip girdle muscles, the abdominal wall muscles, as well as the postural muscles of the back, making the pelvic floor truly the floor of the core. So they're responsible for stabilizing gait, posture, maintaining urinary and fecal continence and control, supporting the entire weight of the abdominal and pelvic column from the diaphragm on down, and optimizing sexual function. So pretty important stuff. So pelvic floor disorders are, broadly speaking, conditions that affect the normal function of the pelvic floor. This is a nice quote from the patient-facing site of the American Urogynecologic Society called Voices for PFD, or pelvic floor disorders. And it's a great primary resource for patients wanting to learn more about pelvic floor disorders. Next slide. So when the normal functions of the pelvic floor are disrupted, pelvic floor disorders develop. The most common ones include urinary incontinence or unwanted leakage of urine, pelvic organ prolapse, historically sometimes referred to as vaginal prolapse, fecal incontinence, sometimes called accidental bowel leakage. And I tend to think of these top three disorders as being related to relatively irreversible neuromuscular damage. And then there's a broad bucket of pelvic pain symptoms that are related to pelvic floor hypertonicity and myalgia. And I think of these as more reversible neuromuscular dysfunction syndromes, but we'll be talking about them in more depth. So this is a diagrammatic representation of the prevalence of pelvic floor disorders, ranging from isolated, which you see in the pink and that light blue and yellow colors, to very complex. As you can see, by far the most common pelvic floor disorder is urinary incontinence, with 1 in 3 to 4 women affected by urinary incontinence symptoms at some point in their lifetimes. And fecal incontinence is the second most prevalent, with about 1 in 5 women reporting having had at least rare episodes of fecal incontinence by their mid-60s. Pelvic organ prolapse is a herniation of the pelvic organs that results in the protrusion or bulging of vaginal tissue outside the vaginal opening. And this affects roughly 1 in 8 to 12 women in the United States. So even though it is the least common pelvic floor disorder, it's still a relatively common condition. And because the underlying etiology of pelvic floor disorders is neuromuscular dysfunction or injury, it's really common for multiple disorders to exist concurrently in one patient. And that's why it's imperative for us as urogynecologists to evaluate patients for all these disorders, despite whatever the most common or presenting symptoms of the patient may be. Next slide. So what causes pelvic floor disorders? Well, first, a warning, this slide contains some Debbie Downer content. So sometime around our mid-30s, we all begin this process of slow neuromuscular decline. And the trajectory and the speed of this decline is dependent on a lot of factors. Some of them are modifiable, at least to some extent, such as our muscle mass and endurance, our weight, our core strength, our long-term blood glucose levels, and our diet. And others are less modifiable, like our baseline neuromuscular function, our genetics, our comorbidities, and our neurocognitive function. About 81% of US women choose to have children, which we gestate and birth, and pregnancy and delivery by our anatomic design almost inevitably result in neuromuscular injury to structures of the pelvic floor, which represents a nosedive or a substantial decline in neuromuscular function. And some of this lost function can be and is recovered, and some of it isn't. And there's really little data right now that's available today to guide individuals about how to best approach recovering this function after birth. So nerve injury, muscle injury, and the oxidative stress of aging and other comorbid conditions cause this nonlinear decline in neuromuscular function until it hits a threshold at which symptoms of pelvic floor disorders develop. And the severity of symptoms seem to be related to the severity of neuromuscular deficit, and probably the relative prevalence of specific pelvic floor disorders have to do with the neuromuscular injury threshold for symptom development. For example, as we saw on the last slide, urinary incontinence is the most common pelvic floor disorder, likely because it doesn't take profound neuromuscular injury to upset the delicate balance that's necessary to maintain urinary continence. On the other hand, pelvic organ prolapse is less common, and the herniation of pelvic organs through the pelvic floor musculature likely indicates a significantly higher level of neuromuscular injury and dysfunction, if that makes sense. We can go to the next slide. So I think this slide nicely exemplifies the high prevalence of urinary incontinence, shown as 30%. There's the highest bar graph in orange in women relative to the airtime that it gets compared with other chronic medical conditions, as well as the time it gets in medical education curricula, patient education resources, research dollars, et cetera. It's part of that sisterhood of silence that we started talking about. Next slide, please. So as our population ages, and as, can you go to the next one, actually? Yeah, and as we live not only longer lives, but actually expect these lives to be full and active into our 7th, 8th, and 9th decades, the prevalence of pelvic floor disorders will continue to grow. In fact, based on current models, the number of women seeking surgical treatment for pelvic organ prolapse alone will increase from roughly 166,000 in 2010 to 246,000 by 2050. So this underscores the importance of proper evaluation and surgical selection to deliver high-value care, especially to patients with multiple or complex pelvic floor disorders. Can you go back to the previous slide? Thank you. So next, we're just going to spend a little bit of time talking about common pelvic floor disorders and their treatments. So the most common, as we mentioned, is urinary incontinence, affecting about 1 in 3 US women. And the majority of these are undiagnosed and they stand to benefit substantially from available treatments. So let me pause here and pass the baton to Abby Shak-Margolis to tell you a bit more about urinary incontinence.
Thank you, Olga. Yeah, I think now the stage is set. You can recognize that these are quite prevalent and greatly affect quality of life in patients' daily living. I'm just going to take a step deeper into talking about 2 of the most common urinary incontinence presentations we see, that being stress urinary incontinence and urgency urinary incontinence, and give you a brief overview of kind of what we can offer patients to improve their quality of life and have them meet the goals that they want to. Stress urinary incontinence is basically, do you leak with coughing, sneezing, exercise, or any other exertion? And does it affect your daily routines or daily quality of life? As Olga has touched on, this has to do with a weak sphincter, weak pelvic floor muscles, and an unwanted leakage of urine amidst exertion. So we can really approach a patient with stress urinary incontinence in 2 different ways, surgically and non-surgically. And non-surgically, we're looking at strengthening the pelvic floor muscles with or without the assistance from our pelvic floor physical therapy colleagues, or the use of incontinence devices. Commonly, we fit patients for something called an incontinence pessary, or a silicone ring that sits in the vagina, basically to add a backboard of support to that urethral sphincter area. There's also a slew of over-the-counter products that patients are becoming much more savvy with, and these incontinence devices can also help patients with predictable stress urinary incontinence. In terms of procedural and surgical, we offer an office-based procedure called urethral bulking, which really reduces the episodes of leakage, maybe doesn't cure as much as our surgical intervention, but it can really help patients who are having less of an impact on their daily quality of life. And then our other surgical intervention, primarily we're talking about a synthetic mid-urethral sling, which is an outpatient 30-minute procedure with very high success rates in the 80 to 90%, with a very short recovery period, maybe about 2 weeks of reduced activity, that patients are incredibly satisfied with. I'll go to our next slide and delve a little bit into urgency urinary incontinence, which is really like a totally different mechanism than stress urinary incontinence. It has much more to do with the innervation to the bladder and coordination of the bladder muscle or detrusor muscle contraction. And this is the patient who comes in and says, I just can't get to the bathroom. I know where every bathroom is on the way to and from work. And if I don't stop at exactly those points, I'll leak on the way to the bathroom because I have a sudden urge to empty and I can't defer it. I can't hold it. This, again, greatly affects people's quality of life, their ability to be spontaneous with their activities or join family members for different outings, etc. And we, again, can approach this either non-surgically or with more interventions. And I'll delve on that in a second. In terms of the non-procedural, non-surgical, we can guide patients on behavioral changes, retraining their bladder, avoiding certain irritants that might bring on more bladder contractions in their daily life. And then there's medications that directly affect the ability of the bladder muscle or the detrusor muscle to contract. When patients fail those interventions or are still having an impact of their symptoms after trying those symptoms, that tends to be when they're referred to us. And then we talk about more third-line strategies, which involve things like neuromodulation, which essentially speaking, we have like an acupuncture type needle that we stimulate with an external pulse generator. It's kind of like a little walkie-talkie that can connects to the needle and stimulates a peripheral nerve that goes to the same nerve root that controls detrusor muscle contraction. So this is something we can offer patients in our office. It takes 30 minutes. They come once a week for 12 weeks, and they can see a 60 to 70% improvement in symptoms. Another intervention in the realm of neuromodulation is a surgical intervention called sacroneuromodulation. They actually have that pulse generator implanted, and so it's there always, and patients also report somewhat similar improvements. And then our other, probably more commonly used intervention amongst our practices called bladder Botox or intradetrusor Botox. So we actually inject botulinum toxin right into the detrusor muscle to temporarily relax it, so you're not having those unwanted and frequent bladder spasms. That's our most common intervention to get people dry and cure, and it really helps people regain the quality of life that they're looking for. We'll go to the next slide. Stepping away from urinary incontinence, another very common diagnosis we see is pelvic organ prolapse that Olga has touched on, is the sensation of vaginal bulge or tissue protruding outside of the vaginal opening. And it can be thought of as a herniation of the pelvic and abdominal organs through the pelvic floor muscles. This again can greatly affect someone's ability to be active, do the things they want to be doing, and it can even affect bladder and bowel function. Pelvic organ support is a continuum. So if we examined 10 patients from out in the population, we might find a slew of them have measurements suggestive of pelvic organ prolapse. But unless these symptoms are bothersome to a patient, it's really not considered prolapse, and it's not something that we would ever recommend intervention for. And just like urinary incontinence, we kind of think about intervention as non-surgical and surgical. Our non-surgical interventions might be strengthening the pelvic floor, again, with or without assistance from our physical therapy colleagues, or using a prolapse pessary, which is a similar silicone ring that sits into the vagina and provides mechanical support of the pelvic organs, and then a slew of surgical interventions. All three of us here provide minimally invasive vaginal robotic approaches to surgical treatment of prolapse. And then we can go to the next slide.
I think this is where I take over.
I'll pass the baton to Caitlin.
Thank you so much, Abby. So I get to round out our discussion about the different pelvic floor disorders, this rapid fire kind of review, and talk about accidental bowel leakage. And so this is usually not the patient's most favorite topic to talk about, but it's exactly what it sounds like. It's the loss of normal control of the bowels leading to leakage of stool, that is fecal incontinence, or leakage of gas, which is anal incontinence. And it's actually a more common problem than one might think. And we suspect that this prevalence that I cite here is actually likely an underrepresentation because of the shame and embarrassment that's associated with accidental bowel leakage, and patients not wanting to bring this up with their primary care providers, with even their urogynecologists. But it is very common, 6% or so of younger women, that is women under the age of menopause, and 15% of older women experiencing this during their lifetime. And it's even higher in our older population that are potentially institutionalized. What I mean by that is patients that are in a skilled nursing facility or a nursing home, or even higher rates, approaching 30 to even 40% in that patient population. And while it's a common problem, it's associated with significant quality of life for patients. I would say anecdotally, it's not the most common thing that I see presenting to my clinic because of that shame factor. But when the patients do present with this, they are significantly bothered by this, and it leads to things like social isolation, embarrassment. So a common thing that I hear is, I don't want to go walk with my friends because I may poop my pants, or I may have a smell associated with it that I will not go out. I have completely changed my life around this, and I don't want to leave my house. It has led to loss of employment, as well as loss of a sense of self, which can be associated with intimate relationships or even self-esteem. And, this potentially prior active patient who now is just not wanting to leave their house. And it behooves us to query our patients about this, to ask them, are you experiencing this and how often? Because there are things that we can do to help. There are things that we can do from as simple as just changing stool consistency by talking to our patients and offering dietary modifications, making sure they're getting enough fiber, making sure their stool is of a consistency that's easy enough for the rectum to control, to something like physical therapy, biofeedback, working with our partners both in gastroenterology as well as in colorectal surgery and some of our advanced practice providers. And in addition, we can offer other things like vaginal support devices that actually help bowel leakage. In addition, there is some evidence to support neuromodulation in the same way that Dr. Shakin-Margolis spoke about urinary leakage that can help with accidental bowel leakage. And to a less extent, there are some surgeries that are available in the right patient. Moving on to our last pelvic floor disorder to kind of wrap up this foray, I wanted to spend a little bit of time talking about pelvic floor myalgia. And you may hear this called something else: high tone pelvic floor, non-relaxing pelvic floor dysfunction, many different names for this really syndrome that affects the pelvic floor musculature and myofascia. By definition, it's characterized by short, tight, tender pelvic floor muscles with myofascial trigger points causing local and referred pain. And the referred pain, I think, is very key here, because what I like to think of pelvic floor myalgia as this great masquerader. So sometimes I see patients in my clinic that have this wide array of symptoms, and they say, I've been diagnosed with recurrent UTIs and I can never feel like I can get my poop out, and sex hurts, and oh yeah, that. And then all of a sudden I say, has anyone actually evaluated the myofascia of their pelvis? And my antennas go up and I do that exam, and lo and behold, they have really tight, tender, non-relaxing pelvic floor muscles. And I say, hey, we can help you with this. And the treatment of choice for this is actually pelvic floor physical therapy. So I'll talk about that in just a second, and really how we can involve our pelvic floor physical therapy colleagues in this treatment. But I just want to talk about a little bit more of some of the associated symptoms. So obstructed defecation or pelvic floor dyssynergia. So as Dr. Ram started our talk off talking about, what the pelvic floor was and what it needs to do, it really needs to be a coordinated effort. And once that becomes uncoordinated, it can lead to things like chronic constipation, obstructed defecation, inability to feel like you're fully emptying the bladder, irritative voiding symptoms. So this feeling of constantly needing to feel like you need to go to the bathroom, and feeling like you're not emptying, plus or minus associated with pain, along with the wide array of pelvic pain syndromes, which can be dyspareunia, pelvic pressure, vulvar pain, or just this chronic catch-all of chronic pelvic pain. And what I would say here is that the pelvic floor myalgia could be a symptom, it could be the etiology, or it could be a contributing factor. We don't necessarily know. It can, it is complex in the way that it interacts with the viscera, but if it's not addressed, whether it's not the true etiology or pain generator, if it's not addressed, it can cause other symptoms to persist despite us treating the other pelvic floor conditions. And so, where people really get the best care for this is with our pelvic floor physical therapist. So I just want to give them a shout out here. At UCSF, this is just 3 of our pelvic floor physical therapists, but at UCSF, we actually now have 9. We've hired up to 9, and they are seeing patients at several different locations throughout the Bay Area, including now moving out to the Berkeley Outpatient Center. And they're also helping at Montgomery Street in the gender affirming care, really providing full scope care for the pelvic floor and the myofascia pelvic floor. I put their referral information up here because the state of our healthcare system is now such that sometimes patients have a long wait to see a urogynecologist, and then a long wait to see pelvic floor physical therapy. And I want to give a plug that if you yourself as a patient feel like you would benefit from physical therapy, or you as a provider feel like your patient would benefit, then you can go ahead and refer directly to them. We are not the gatekeepers of getting referrals to pelvic floor physical therapy. And so starting pelvic floor physical therapy can make huge impacts in the patient's care and get them improved quicker. And so I just wanted to throw them up here as a wonderful referral, as well as great partners in our care, multidisciplinary care of pelvic floor disorders. And then lastly, this is just what we offer. This is not a comprehensive list, but I just wanted to put it all on one page as you know, Dr. Shakin Margolis and I spoke about the different options that we offer as urogynecologists to our patients, basically the breadth and scope of from behavioral and non-surgical management to surgical approaches to these conditions. And what I would say our approach is really a shared decision-making model where we take our expertise and the evidence, the best evidence-based care, as well as our experience with different patients, and we partner with our patients with who they are, where they are, you know, where they are in their life spectrum, as well as their goals of care, and create a treatment plan that is suited for them. And that includes both the non-surgical management, but also in particular the surgical management. So there's not one surgery that fits all, and the decision for surgery and the type of surgery definitely depends on the patient, their lifestyle, their goals of care, and their expectations. And so our model here is a shared decision-making model to help patients basically get to what they want their life to look like the best that we can. So from there, you know, I'm just going to turn this back over to Dr. Ram, where we can talk a little bit about what our future directions are as in our division and the care of women with pelvic floor disorders.
Thank you, Caitlin. I can't underscore that enough. And I'm fortunate to work with a group of people who are really on the same page about providing an individualized, patient-driven approach to these disorders that essentially are quality of life disorders, and partnering with patients, providing them with the highest level of information and acting as the coach to help them arrive at the decision that is going to be best for them. So far, we've really focused kind of on the pathophysiology of pelvic floor disorders. And I want to spend a little bit of time pivoting and talking about it from kind of a more humanistic provider standpoint. So Caitlin, Dr. Painter, can you tell us a little bit about what drew you to the field of urogynecology and maybe what continues to inspire you about your clinical work today?
Absolutely. So what first drew me to urogynecology was really the postpartum or peripartum pelvic floor disorders and the care of women in that, or patients in that immediate postpartum period, as well as some of the counseling and education that goes around that. And it's really continues to inspire me as what I may want to do for quality improvement projects, my research interests as well as systems-based practices that we can change for patients that are in the postpartum period. Because pelvic floor disorders are incredibly common in the postpartum period. There's 60% of patients will have at least one pelvic floor complaint immediately postpartum, and up to a third of those patients will have persistent symptoms at 6 months and a year. And, you know, what I think about is my patients, right? So I have a particular interest in obstetric anal sphincter injury and the care of those patients, and have spent some time working in postpartum perineal clinics and doing research in that arena. And I have heard just countless patient stories of, I didn't know, nobody told me, I wish I would have known this. And I also hear it on the other end of the spectrum. So I get patients in their 70s who say, oh, you know what, this is probably because it all probably started back when I had that forceps delivery and an episiotomy, and what could I have changed, you know, in hindsight. And so my goal as I continue my career is to continue working on research in that arena, as well as patient education, provider education, and really just putting the spotlight on what we can do to help prepare women for the changes that are going to happen, and potentially some of the symptoms that they may feel related to pelvic floor disorders, and in that also create potential quality improvement projects so we can continue to improve care for these patients. And so I'm going to then throw the question back to you, Dr. Ram. What do you think patients should know about pelvic floor disorders? What do you think we're lacking?
Well, in the vein of that, breaking that sisterhood of silence, I think that women should inform themselves about the symptoms of pelvic floor disorders so that they can seek treatment, because effective treatments do exist. And I also think that we need to start being honest with women about the limitations of currently available treatments, some of which might be overcome in the future with research and novel technologies, and some of which may not, because sometimes an ounce of prevention really is worth a pound of cure. In my previous position, with your help, Caitlin, as you well know, I helped start and ran the Kaiser Permanente Northern California postpartum perineal clinic, where we took care of women with anal sphincter injury and, all sorts of varieties of severe perineal trauma. And like you, the thing that I heard most often was, wow, I never even knew this could happen. And that really motivates me to break the silos between obstetrics and urogynecology, because decisions that are being made in the labor and delivery room often have profound implications for the health and quality of life of the mother for decades, for like literally the rest of her life. And women deserve to know and understand the risks that that birth and various modes of delivery pose to their body. I feel like they should be fully allowed to participate in these decisions, just like we have informed consent for patients undergoing appendectomy or cholecystectomy or cesarean delivery. We should be having similar discussions with our patients prior to a planned vaginal delivery. And I'll now get off my soapbox. Abby, let me ask you a question. What do you think sets our UCSF Urogynecology division apart and makes it the best place to receive care for pelvic floor disorders?
Great. I love that question. Let me tell you, I would never pass up the opportunity to share what makes UCSF the place to get your urogynecologic care. As you can see, our primarily female group of clinicians brings to the table a very robust and diverse clinical training and experience. We collaborate regularly with one another on complex clinical and surgical cases. And furthermore, we have well-established relationships with our colleagues in the colorectal surgery group, urology group, gastroenterology, and you've heard with pelvic floor physical therapy as well. These relationships are what foster a multidiscipline approach to care that is so crucial when caring for our patients suffering from complex pelvic floor disorders. And in fact, we are currently underway creating the first truly integrated multi and interdisciplinary pelvic floor center right here at UCSF. So stay tuned. If hearing from my two wonderful colleagues about their passion and what inspires them doesn't emphasize enough what makes us such a great place to receive care, wait till you see this pelvic floor center. We're really excited.
So this slide is basically here to help the UCSF community and anyone who might be listening at large streamline referrals We hope that the information that we shared with you really empowers all of you to refer patients for care of pelvic floor disorders. You can refer to us via Apex. The referral is for urogynecology within the Department of OBGYN or obstetrics and gynecology. You can also fax a referral. You can email us a referral. And if you need to expedite something or have a curbside or an unusual question, please reach out to us by email. We're all super responsive and always happy to help. We have
We do have a few questions that I'll read out. And there are some symptoms related to pelvic organ prolapse. It seems like that was most of the questions. But I will, maybe throw this question out to Abby. So the questions were about Kegel exercises being preventative and devices like the PeriFit for urinary incontinence. So if you wanted to take like 1 second to 2 minutes maybe to talk about Kegel exercises and the PeriFit.
Great. Yeah, thanks for those questions. Kegel exercises or pelvic floor muscle contractions. We commonly hear, do your Kegels when you're at a red light or when you're going to sleep at night. In terms of prevention, I think it's very important to have knowledge about how the pelvic floor muscles work and that they are part of our core strength, just like our abdominal muscles. So any exertional effort where you would be engaging your abdominal core muscles, it's important that we educate women and all comers that you need to engage your pelvic floor muscles as well, basically to protect your pelvic floor when doing any heavy load exertional activity. In terms of patients with pelvic organ prolapse and do pelvic floor muscle contractions treat pelvic organ prolapse, we do know that patients with lower stage or less advanced prolapse who do regular pelvic floor muscle contractions, Kegel exercises with or without assistance from our physical therapist, we can see about 50% of those patients go backwards a stage or improve their prolapse measurements. Whether or not that coincides with symptom reduction is really a case-by-case scenario. I can tell you that in my practice, I don't typically encourage Kegel exercises as a preventative strategy, but instead in patients, I educate them about, when you go to lift a bag of groceries or you go to lift your young kid, that's a time that you really want to focus on exhaling the breath, contracting your abdominal core and your pelvic floor core at the same time. Those types of just behavioral changes in your daily routine are going to be far more impactful on protecting your pelvic floor than going to bed and doing 10 Kegel exercises each night. The second part of the question.
Oh, yeah, PeriFit.
PeriFit. I'm not sure I can speak intelligently about that device exactly. I don't know if Caitlin or Olga, you want to chime in, or I'm happy to look up that specific device. In general terms of incontinence devices, they can be very helpful. It's very much specific to the patient, and if the urinary incontinence is occurring at a predictable time, for example, we have patients who may go to a Zumba class once a week, or when they hike on a certain incline, they have accidental leakage of urine. In those instances, those devices can be very helpful. Other patients of ours, the accidental leakage of urine is happening at all different times of the day or during all different types of activities or with urgency, and they're not as predictable, and they may feel that those devices are meeting their goals less. But again, if Caitlin or
I can answer a little bit. So PeriFit is one of the sort of intravaginal biofeedback devices that are now available. There is multiple now, and typically they interface via Bluetooth technology with a phone or something to do home biofeedback, essentially to make sure that you're contracting your pelvic floor muscles appropriately and try to strengthen that. I'm not aware of any evidence for PeriFit specifically. However, there has been multiple trials done on a device called Leva, which is similar and is available to purchase over the counter, as well as with is now being covered by some insurances, and that it has shown benefit to prevent stress urinary incontinence with activities with, so something similar like that. So essentially a biofeedback approach to Kegels. And then someone else said, I was told not to do Kegel exercises, but the happy baby for urinary incontinence. And is that okay? And I think this gets into the what Dr. Schecken-Margolis was saying a little bit about that, you know, it's not just all Kegels for everyone. What I would say is that pelvic floor disorders are multifactorial, and while someone may have zero Kegel strength and are unable to recruit and coordinate the pelvic floor muscles, another person's pelvic floor may be hypertonic and tight, and they may not be able to relax that pelvic floor appropriately. And getting a pelvic floor exam to kind of assess the tone and the coordination of the pelvic floor can be helpful to help guide exercises. And then this is where we kind of link in the pelvic floor physical therapist, because the pelvic floor needs to be a coordinated type of function. Moving from that, I'm going to ask this question to Dr. Ram, because I know she loves this answer. So how common is it to have a repeat urethral sling years later?
Yeah, so it really, that's a great question. And there's no shelf life to a sling. I oftentimes have patients come and say, oh, I've heard you got to get one of these every 10 years. And it's actually a little bit more complex than that. You know, we talked about sort of the neuromuscular dysfunction threshold for developing pelvic floor disorders like stress urinary incontinence. And let's say that, you know, for patient A, she crosses that threshold in her early 40s. And we implant a midurethral sling, which is sort of the gold standard first line surgical approach for stress incontinence. And she's cured. Her neuromuscular function is still declining, and there are things that she can do to slow that decline, and hopefully that decline will be slow enough that she's going to get several decades of the sling being able to keep up with the neuromuscular function and keeping it above the threshold for symptom development. But, you know, potentially 10, 20, 40 years from implantation, her neuromuscular function is gonna get below that threshold again, despite the sling. It's a little bit, you know, the analogy I use with my patients commonly is, let's say you have diabetes and you're started on insulin, and 10 years later, your dose of insulin is double what it was when you started. Well, is it because the insulin stopped working? Well, it's the same insulin. Your diabetes got worse. And so same with this neuromuscular condition. And, you know, oftentimes it's helpful for people to understand that the surgical risk to this relatively minor procedure is, you know, similar at age 30, 40, 50, 60, 70. But the potential benefit is obviously what's different. In other words, the longevity of effectiveness of the sling may be higher in patients in their 40s or 50s than it is in patients who get these implanted in their 70s or 80s when neuromuscular decline rates accelerate. That might have been too wordy of an answer, but hopefully that makes sense.
I think another question on here is symphysis pubis dysfunction correlated with any of these pelvic floor disorders? I can field that question. So pubic symphysis dysfunction is most certainly related to pelvic floor myalgia, and the high tone pelvic floor, specifically abdominal pelvic pain disorders, because it has to do with stability with the core. So as Dr. Ram mentioned in the beginning, we talk about the pelvic floor, but we also talk specifically about the pelvic girdle. The pelvic girdle includes some of the big muscles of support, including the gluteus maximus and the psoas muscle, and the pubic symphysis dysfunction is related to instability in that pelvic girdle, specifically most often in the postpartum period. And when the pelvic girdle is not properly aligned, you can get pain in the joints. So this is going out into the realm of potentially our PM&R colleagues and our orthopedic colleagues, as well as our pelvic floor physical therapists. But a good musculoskeletal exam and working on core and pelvic girdle stability with our pelvic floor physical therapists can really help that. But pubic symphysis dysfunction is not specifically correlated with, for instance, pelvic organ prolapse. I hope that answers that. I think we're getting more questions. I'll keep trying to go through this. So hormone replacement therapy and urinary urgency. Dr. Sheck and Margolis, do you want to answer that one? So I think the question is, does hormone replacement therapy help with urinary urgency?
So hormone replacement therapy, being an oral ingestion of hormones, does not help with urinary urgency, but we are getting more and more smart and nuanced with how we are describing changes to the hormonal milieu. And now we have a new diagnosis, genitourinary syndrome of menopause, or there's an even newer one, genitourinary syndrome of lactation. Basically, these low estrogen hormone states are contributing to bothersome urinary symptoms such as urgency, frequency, nighttime waking, dysuria or painful urination, etc. And we know that targeted vaginal estrogen improves these symptoms significantly in up to 80% of patients. So no, I do not prescribe hormone oral replacement therapy to treat bothersome lower urinary tract symptoms. I uniformly prescribe vaginal estrogen, and vaginal estrogen comes in a multiple types of cream, tablet, or a ring that's inserted for 90 days and has a slow release. My personal preference for prescribing to patients is an estrogen cream, which on top of improving urgency, frequency, nighttime waking, dysuria, also greatly significantly reduces the incidence of recurrent urinary tracts in our perimenopausal patients. So yes, everyone should get vaginal estrogen.
Great. Okay. And then there's a few questions about prevention. And I think Dr. Ram, you sort of answered some of this in your last question. So I'll throw this back to you. It basically is, if for someone who already has urinary and fecal incontinence, how effective are pelvic floor exercises in reversing or lessening the frequency? And does this effectiveness vary depending on age?
Yeah, so the data around that is a bit conflicting, and I think it's sometimes hard to compare fairly apples to apples because not all patients are the same, and adherence to physical therapy regimens are different, especially because oftentimes, a course of physical therapy involves not only what happens in the physical therapist's office, but also all of the homework and exercises and behavioral changes that the patients are asked to undertake at home. So specifically for fecal incontinence, I think physical therapy and strengthening that puborectalis muscle, or at least being aware of how to connect to it and engage it, can be actually quite helpful. I think that urinary incontinence, the longevity of the benefit is a bit more mixed, and certainly whether it is non-surgical or surgical treatments, sadly, the best predictor of outcome is your baseline neuromuscular function. So the less sick you are, the less you have something, the more likely you are to get better, which you can see it as glass half full or glass half empty, if you will. But the thing about physical therapy and also pelvic floor muscle strengthening and core strengthening is that there's really no downside to trying this. Right. I mean, I tell a lot of patients who are recently postpartum and are like, do I really have to do all these Kegels? You know, just as Abby was sharing with you, no, you don't necessarily have to do Kegels, but why don't you just go and strengthen your core, or take an hour or two out of your week to go do something for yourself, like an exercise class that you enjoy that focuses on core strengthening. Because not only is that going to help ward off pelvic floor disorders potentially in the future, there's actually a very nice, small, randomized clinical trial where women do specific pelvic floor muscle strengthening exercises or similar frequency of Pilates classes, and the outcomes and benefit is very similar. So just do these things to strengthen your core for pelvic floor symptoms, but also because it's just good for you. It's going to prevent low back pain, help ward off injury, etc.
Okay, we have a few more questions and a few more minutes. So the next question was, can you feel discomfort or pain during orgasm at the belly button region with pelvic floor dysfunction? And the answer is absolutely yes. As I had said earlier, the pelvic floor is definitely a great masquerader, and it often refers pain. And as all of these muscles are interconnected and the fascia is interconnected, often people with pelvic floor spasm will have anterior abdominal wall spasm, which then can refer pain to the belly button. That is definitely yes. And then this next question says, in terms of prevention, what can relatively healthy women do to maintain pelvic floor health? I think Dr. Ram just addressed that very well. So being active and healthy. And then the second part of that question was, are there guidelines to refer to a urogynecologist? And I would say there's not necessarily guidelines to refer to a urogynecologist. If you suspect any of these pelvic floor disorders in your patient, certainly you can refer. If you have taken some of this information and said, hey, I think that I could definitely get someone to physical therapy, or I could start them on, some of the different options that I have heard of today, I think that's very reasonable. And, even if a patient just wants to come to us for consultation and education, but don't necessarily want to move forward with, big invasive treatments, I also think that that's very reasonable. So I wouldn't say there's a set guideline of when to refer. And then another question here is, what approaches for rectocele from first diagnosis to more severe? So in just, the few minutes we have left, I will just answer this and say that a rectocele is in the spectrum of pelvic organ prolapse, and it is isolated to the posterior compartment. But what we know about studies is oftentimes pelvic organ prolapse comes together, and we like to think about that, as we were saying before, as a herniation through the pelvic floor. And it is often both the apical, or the top part, the anterior wall and the posterior wall that come together. So we're moving a little bit away from just rectocele terminology, but just a brief discussion of what are the treatment options. So it ranges from pelvic floor physical therapy and muscle strengthening to a pessary or a vaginal support device, to surgery. And for surgery, that can be a vaginal surgery without the use of mesh augmentation, or this can be a minimally invasive abdominal surgery with the use of mesh augmentation. And that can be an entire lecture in and of itself. And so that's just kind of my brief discussion of rectocele. I think I may have gotten to all of the questions. I think Lauren put a QR code in the chat as a survey. I do believe that this was recorded because there was a few people asking for a recording. And then just to close us out, I'm going to turn this back over to Dr. Ram to just give us some final wrap-up thoughts.
Thanks so much. I want to thank all of you again for sharing some time in your day with us to hear about our life's work. And hopefully, like I said, this will leave you empowered to seek care, if not for yourself, then for friends, neighbors, family members, and patients of yours. So please don't hesitate to reach out. We see patients in the Mission Bay location in San Francisco, and we also have the East Bay location in Berkeley. And we also do telehealth via Zoom, especially for those patients that maybe require a bit more education or don't have specific symptoms, but want to talk about prevention. Thank you all so much, and have a great rest of your day. Happy International Women's Day.
Thank you all.
Yeah, thank you so much. I'm going to put the QR for those of you who are still here. I'll put that quickly up on the screen. Please do fill out our survey. Take a moment to do so. But otherwise, thank you, Dr. Ram. Thank you, Dr. Painter. Thank you, Dr. Shatkin-Margolis. This was awesome. This was great.
Here, bye-bye.